on behalf of the Shelby Hospital, and this activity is under the name of PT of the Shelby Academics and Department of Orthopedics, and this is a venture we have entered into just to update you in various fields in orthopedics. We are trying our best to get the faculty across so that you will have a cross-sectional views in orthopedics. Let us today is the basic examination of the hip. I'm going to do it, and the clinical examination of the hip in detail. It might take a little time, but if you have any question in between, you can interrupt me so that you get a clear idea. So there is some part you should also discuss and also try and prepare so that you are going to take a part in quite a bit of discussion. Second important thing, you will understand better. So it is better that you have a preparation before coming for this lecture, so it will help you. Anyhow, clinical examination of the hip is we'll just discuss a little bit of basic anatomy also, and history taking is an art, because most of the time, almost 80 to 90%, we are reaching to the near diagnosis by just taking history. Most of us orthopedic surgeons have no patience at all. So we just, when the patient comes in front of us, we don't see them coming walking itself. If you just see walking, probably quite a bit of diagnosis we will be able to make it. Number one. Number two, we will just start looking at the file rather than asking patients. Rather than patient. On many patients will come and tell you the diagnosis. I got, sir, avascular necrosis of the femoral head. I got the AVM. That is the way the patients are coming with the files and their Google search. So you don't rely on that. So most important is clinical history taking, and it is really art. And this is not difficult. Absolutely not difficult. Because if you develop a repetitive skill, then you will automatically get that habit of getting a clinical history. So it is not difficult at all. You have to learn by repetitions, nothing more. As all, if you know, it's a ball and socket joint, synovial joint. The most important is it connects the pelvis to the girdle, of the lower limb, and that's why the whole stress goes into the lower lumbar spine and the sacroiliac and all of the area. So this is a connection. The hip is a connection between the trunk and the lower limbs. So if it is a connection, it requires quite a bit of stability and also requires a wide range of movement. And that's for reason this hip has got a great movement. It's almost like a shoulder also. Like a shoulder. That's the amount of movement the hip also has. And the articular surface is horseshoe-shaped. There is a small deficiency inferiorly in the acetabular notch area, just above the transverse acetabular ligament. That area does not have any articular cartilage, and that contains usually fat, fovea, and that is very important to identify the medial wall of the acetabulum. This structure is very important for surgeon. Also, when the fusion takes place, when the hip gets fused, this part of the fat does not get fused unless it is surgical done fusion. It is on spontaneous fusion. This pad of fat in that area, horseshoe area, will be always available, so that you know this is the most medial wall of the acetabulum, and we don't ream beyond that. So this is a very, very important as a surgical and for a surgery. And another important thing is labrum. Labrum is also a very, very important structure. It is a circular all around, except the inferior portion. Also at the level of the tal, the labrum is absent. Why this labrum is important? Because it increases the stability and the depth of the acetabulum. And this structure you have to preserve when you are doing a bipolar hip replacement. If you exercise or damage a labrum, this hip will start dislocating. and that is important of labrum in case of when you're doing a bipolar orthoplasty. So very careful in preserving complete labrum. Otherwise, the hip will start dislocating because the depth gets reduced. So one of the few ligaments are important. Iliofemoral ligament. This is the strongest ligament which connects the pelvis to the femur in front of the joint. It's a very wide structure. It comes in the front, it comes superiorly, it comes partly on posterior also, which I'll show you. It resembles like an inverted Y. So this is the part of the iliofemoral ligament. It stabilizes the hip by limits the hyperextension. Allows flexion, but it limits the hyperextension, and it's a very strong ligament. And when we are doing an anterior approach for the hip, this ligament is completely preserved. We reflect the whole thing in the front of it, and this, after doing anterolateral approach, we just put it back and suture it with a soft tissue, and this strong ligament does not allow the hip to dislocate, whatever the position most of the patient take. Okay. The second ligament, that is the iliofemoral. The second ligament is ischiofemoral ligament. This ligament which reinforces the posterior aspect of the capsule. So if I told you, the iliofemoral ligament also comes quite superiorly and part of the posteriorly. Only the ischiofemoral this is the green portion, which is the ischiofemoral ligament. This is not a very strong ligament. That's why we have problem when we do a posterior approach. This ligament and the capsule is usually very thin, and that's why the repair always becomes difficult and the hip dislocation takes place. This is one of the reasons that the anterior capsule and the iliofemoral ligament is very strong, does not allow to dislocate. Unfortunately, the posterior ligament, ischiofemoral ligament, is a weak ligament, and the capsule is also not very strong posteriorly, and that's the biggest problem. The other is the very short and small ligament is a pubofemoral ligament. This is shown in a blue, goes underneath, and that's a pubofemoral ligament. It's not that important ligament. So ischiofemoral ligament reinforces the posterior of the capsule, attaches from the ischium to intertrochanteric line, almost to the intertrochanteric line. That is the extension of the ischiofemoral ligament. So pubofemoral ligament attaches pubis to the femur, and that is in the front, and that's the pubis, and that's your ligament here. That is your pubofemoral ligament. That is the front. The transverse acetabular ligament, it bridges the acetabular notch. There is a notch in the inferiorly, and that bridging is taken by the tal. That is transverse acetabular ligament. This is important structure to align the acetabular cup. When we do a total hip, we actually align this cup according to the parallel line of the tal, and this was described by Beverland from Ireland. This is one of the very important paper, came back around 10 years back, 10 to 15 years back. And on this ligament, all acetabular placements are taken place. Even navigation is also related to the tal, nowadays tal. So for you, if the shortener comes on the tal, you need to write all the details of this. The tal does both the things. Tal does the anteversion and as well as abduction angle. If your acetabular cup is exactly parallel, that means it is a normal anteversion. Number two, it is 45 degrees of abduction angle. If the tal is not seen at all, that means your alignment may be anteversion, but your cup is vertical. The hip will dislocate. Number three situation, when the tal is seen too much and the cup is right inside, almost 1 centimeter inside, that means your version is all right, but your acetabulum is horizontal and it will produce impingement. So the tal does version as well as the abduction angle. It's called the opening angle. ligament of the head of the femur, which you know that flat triangular shape which lies within the joint is encircled by a synovial sheath. So it is always called intrasynovial extracapsular, articular. So what I need to show you, this is the tal. This is the most inferior portion, and that's your ligament there, and this is your tal. One important thing, the tal gets completely intermixed with the capsule. And how to identify sometimes, you have to take an artery forceps and poke it in this area, probe in this area. The artery forceps will not go. That is the tal. If the artery forceps goes, that means that's not a tal. So that is another important landmark how to identify the tal. Some of the muscles are important. So gluteal muscles, gluteus maximus, medius, and minimus and maximus. See, this is your gluteus maximus attaches from the ilium, traverse laterally into the greater trochanter of the femur. Medius and minius, they abduct. This is medius and minimus, they abduct and medially rotate. Both of them medially rotate. Whereas the gluteus maximus is an abduction but external rotation. It does a lateral rotation. So these two important muscles, they do abduct and medially rotate the joint and stabilize the pelvis. They are called master muscles of the hip. Gluteus medius in the right there, and gluteus minimus goes slightly in the front. And this is the time where gluteus, normally with the posterior approach, you don't have to touch the gluteus minimus, but with anterior approach, anterolateral approach, you might have to go underneath the gluteus minimus. Quadriceps, as you all know, that 4 quadriceps, posterior latalis, medialis, and additionally is the rectus femoris. All are attached inferior to the tibial tuberosity, but the rectus is the muscle which is a biarticular, which Dr. Ganjuwala has explained you very beautifully during cerebral palsy. So rectus femoris originates at the anterior inferior iliac spine, and it acts as a flexor of the hip, and the 3 other cords, do not cross the joint and attach to the greater trochanter, are just below it. So it is a flexor there, and it is an extensor at the level of the knee. So that's the importance of the rectus. And this is a special test. We will come to that special test. Iliopsoas consists of 2 parts. It is a primary hip flexor, and it consists of 2 parts. One is the iliacus portion, which is coming from the inner wing of the ilium, and the psoas comes from all the transverse process and the side of the bodies of the vertebrae, and they both together join and becomes iliopsoas, and it attaches to the just below and behind the lesser trochanter, and it crosses the hip joint. Hams, 3 muscles on the back side attached superiorly to the ischial tuberosity, and inferiorly they cross the knee. So again, these are biarticular, and that's why they can be hip extensors and they can be knee flexors, which also Dr. Ganjuwala had pointed out very beautifully in the last couple of lectures. So these are 2 important muscles. They are biarticulars. They are crossing the joint, 2 joints. That's why it's called the biarticular muscles. In function, just roughly get your idea which are the primary, which are the secondary muscles are. Flexor is the primary muscle, is the iliopsoas, but sartorius and rectus also as a flexor. But the main flexor is the iliopsoas. The extensor is the gluteus maximus, but it is assisted by hams because it is crossing the 2. And adductor magnus is also a part of the extensor. Then adductors. The primary adductor is the adductor longus, supported by brevis, magnus, gracilis, and pectinis also. the abductors and the master muscle is the gluteus medius, but is supported by minimus, TFL, and part of the external rotators. The main external rotator are obturators, and internal rotator is the, I had told you, gluteus minimus. Medius and minimus, they both are internal abductor and internal rotator. And TFL is also part of the, he does abduct and as well as does internal rotation. So this is just a rough idea. Nerves are usually on the hip is femoral, 3, 4, 4, obturator also, and sciatic. So all three nerves do supply the hip area. Blood supply we had discussed in last time, but just to give you a little again brushing up. The main important blood supply is the lateral epiphyseal vessel, which comes from the medial circumflex, and lateral femoral circumflex, which supplies about one third, and artery of the ligament, which is a very small area which supplies into the capitis fovea area. So let us start with some after the basic little bit of here and there. Start the examination of the hip by history taking, general examination, gait. Then we will go on usual story of inspection, palpation, movement, measurements, some special and additional relevant examination. So the first important clinical feature of any patient coming to our clinic is because of the either mostly they come for the pain. More than 90 to 95% people they come for pain. Second, they come for swelling. They are mainly for tumors. So that is the hip is of such a deep muscle. Sometimes it's very difficult. Sometimes with a little synovitis of swelling, the patient will not be able to come, but they come with a pain. Third important, loss of function. Many of our patients don't bother for loss of function. Most of the Western world, they will bother for loss of function, but in our country, the loss of function is a very minimal. Patients come to the clinic for loss of function. Sir, I can't do this. I cannot do cycling. I cannot do this exactly sports. But many Western patients, they will definitely say that, sir, I was able to do this sports, but now I'm not doing. So they are losing a function. The limp, as you see, most our patients do not bother about the limp, but many people will point out there's now you are started limping. The other is a limb length disturbance. So most important patients coming are, first important is pain, swelling, loss of function, limb frequency they come to you. So the pain, the most important is you have to spend quite a bit of time for the pain. So most reported symptoms of pain, I told you, sight. If a patient points at anterior hip pain, that's a groin pain. Usually it is called groin pain. It is usually arthritic hip, that is a common. Can have a sports injury like a flexor or iliopsoas bursitis. Labral tear also do point out anterior pain, and they're typically called as a groin pain. So anterior pain is a hip arthritic or a labral area. We don't have that amount of sports to consider hip flexor strain and other thing. Then if the patient complains on the lateral side of the pain, lateral towards the greater trochanter, so we try to get a diagnosis of sometimes bursitis, maybe sometimes tubercle, we don't know. Gluteus medius tear, which are not very common. So athlete, the iliotibial band syndrome, yes, that is snapping tendon, which is described, can be also a lateral pain. Meralgia parasitica is very important. This is an entrapment of the lateral cutaneous nerve. So the patient will specifically come they'll put on the hand on the lateral side, very specific. And that type of burning is a different pain they elicit. So that's not a normal pain of a throbbing or anything. It is a burning type of pain. You get a lateral cutaneous nerve of thigh, meralgia parasitica. And you have a small regiment patch on the lateral side of the thigh. So it's very classical they get in meralgia parasitica. So you have to listen to the patient actually. We don't listen. That's the biggest problem. The third part is posterior hip pain. Posterior hip pain in the extensor area or external rotator area They are also either coming from the, most of the time, posterior hip pain is always coming from the lower lumbar spine, and they will be pointing towards the sacroiliac and the posterior part. Most of the time is a degenerative disc and not because of any arthritic. So for you, any anterior hip pain is an arthritic pain. Any posterior pain going little down is something coming from higher side. So be careful. Lateral pain, yes, trochanteric and as well as piriformis syndrome and other things which will come to that. So this is the way the pain factor, the site is very important for you. What about the onset? When did it start? When did it start this? So all of you know that if it is acute, that's a trauma. That is a different thing itself. So whether it is hours, days, weeks, year, that will all give you a full idea that this hip pain is acute traumatic or it is a chronic degenerative. That is the way we find out from the onset. Character, sharp. Usually acute pain sharp, there's a muscle or a tear or a fracture. And all dull ache after activities, all other things, after strenuous things, they all dull ache, which is a very vague. They sometimes they are not able to describe that. So these are usually degenerative rheumatoid arthritis, and achy pain is also due to this. And throbbing pain is an infection that you cannot miss. Patient will be howling when it comes to the when they come to the clinical examination, and itself, and he won't be able to sit. He won't be able to even sometimes cooperate. That is the amount of pain they usually have. A throbbing pain in infection. Then, what about the onset site? Radiation? As you all last two lectures, Dr. and as well as Dr. Kulkarni had suggested that sciatic pain that runs from the lower back to the hip and down to the back to the thigh. Any pain below the knee, this is a very important dictum everybody should understand. Any pain below the knee is not to the hip. A pain coming up to the knee is only a hip pain. Any going below the knee, you start thinking that this patient has got a upper lumbar pathology or something else, and it is not hip. This gives you 100% of diagnostic that this patient has if a pain is up to the knee, radiation is up to the knee, this mainly is going to be the hip pain. Radiation to the groin can sometimes, this groin pain, which is sometimes unusual, are usually due to sometimes inguinal hernias, which you actually miss them. So be careful of differentiating from that. The pain, what activity it comes, that is another important thing. So we are considering other things are also, as you know, if it is a fall, that is understandable. If it is a sports, is understandable, either a muscle sprain or labral tear. Classical patient will have a very, those who are in contact sports immediately tell you that I got a groin pain, and the groin pain can be only two, well, either a iliopsoas or a labral tear. Nothing more which can be there. Nothing more can be there. Prolonged after exercise is osteoarthritic. Very gradual, which is a dull aching, gradual for many months, many years, are rheumatoid osteoarthritis versus trauma, which suddenly is a trauma. So it is very easy for you to diagnose. Yes. 1 minute. Yeah, lecture I know. Okay. What are their aggravating and relieving factors are? Pain. Does they have aggravating or relieving factors or not? OA gets worse as the day goes on and relieved by rest. That is an osteoarthritic, any degenerative arthritic hip. Muscle tear sprain may be exaggerated by certain moments. Rheumatoid usually works after prolonged rest, and usually they have a night pain. If analgesia works, find out what they take and how often they take. Also, we have to find out from them. Especially the patient, younger children with a osteoid osteoma, the very classical phenomena, they come with a night pain, and and the relief is with aspirin. That's one of the important diagnostic feature of osteoid osteoma in children. How does pain affect their daily activity? Because when you are examining, when you are finding out whether this man is going to need surgical intervention or not, will all depends on how patient is disabled. If they are only disabled, then they are going for surgical intervention. If they are not disabled, they go for a conservative line of treatment, or they just prolong their activities. So how does the pain affect their daily activity? How far they can walk? Difficulty walking up and down the staircase, whether they need a banister to use, whether they need a support on the side they need or no. So if they need a banister support, that means they are much more disabled. And the walking distance, if they have become less than 200 or 300 feet, that means they are very, very disabled. So very important to ask patient how much you can walk. And now we actually talk on kilometers, but a lot of people, they just talk in the Western world, they talk like a block, so which is difficult to understand for our patients. Are they still able to do their hobbies? Has their partner noticed their pain limiting them? Are they taking a regular analgesics every day? That means the pain is very, very severe. If the patient is every day he takes an analgesic, I think it warrants, for most of the time, it is surgical intervention. This is one important factor in our as a surgeon. So that's about the little bit of our pain and the activity. Then we'll come to the swelling. As you all know, that I don't want to go into the detail, because most of the time it is related to the tumors. Where is the site, onset, duration, associated pain, progression over the time or not, whether it is swelling is static or whether it has suddenly gone up. So that is the way we describe swelling, exactly where the site is. The limp is an important factor for us, and it is usually noticed by KINS. What is the onset, duration, associated pain, progression, what is the ambulatory status of these patients? Most of the time, many of us will tell the relatives, tell the patient that you have started limping, your walk is not proper. So that's the way it is usually picked up. Most of the time, initial phase, patients do not actually notice they are limping. And those who are using either stick or a crutch or other thing, they are much more disabled as far as this is concerned. Past history, trauma, don't always rely in India. All the patients, when they come, you ask after even it is a degenerative hip or whether it is rheumatoid hip also, you ask, did you have a fall? He'll say yes. So don't rely on that. So you have to keep your clinical diagnosis and history both together and then try to match. So don't exactly just rely, because many patients are going to tell you, I had a trauma in childhood, I had a trauma here, I had this and that accident, all sorts of things with it. So don't completely rely on that, except straightforward like acetabular fracture and other things that is different. Transorbital fracture, already surgery done, everything. But when you are going to get a diagnosis of avian, rheumatoid arthritis, degenerative, FAI, dysplasia, trauma is out of question. But they will tell you trauma. So you just ignore the past history, connective tissue disorders, tuberculosis, and this is another important thing, surgery around the hip traction. In childhood, many people will forget, but you'll have to poke them. Did you had any treatment? Did you were admitted in the hospital? Did you have some plaster? Did you have some traction or something like that? That's the way you have to poke them and try to find out if your diagnosis is reaching into the septic arthritis or something else, Tom Smith arthritis or something else. So you have to know what is your diagnosis, and accordingly sometimes you have to poke the questions to the patient, try to get out the answer from them. Very important also is a steroid intake. These are 90% patients are going to tell you that I don't take steroid when they come for avian. But sit for 5 minutes more and try to start asking in a different way. Did you go to gym? Did the trainer give some powder or something? So then you will tell, yes, 6 months I was taking this powder. So this all contains cortisone. Number 2, did you have some skin lesion? Did you go to some skin specialist, dermatologist? Then slowly they will come out. Yes, I had a 3 week of some tablets were given in a tapering dose and something like that. So that's the way we ask the steroid. The third steroid indication in our country is a head injury or migraine. Sometimes some other things are there. So these are, and sometimes our patients go to other specialty like homeopathic and Ayurvedic and other things. So you have to be that also. You have to more and more careful. You have to do and take out the history of steroid. Many patients will have a steroid intake. You may not know the tablet name, but you'll have to find out. Next is any other significant medical or surgical illness the patient had. Suppose the patient was admitted and he was serious, he was on ventilator. Definitely they must have heard use of steroids. That is another important thing we'll have to try to find out from them. Then that will come in. Alcohol also is one of the important factors. Personal history, occupation and work, diet, smoking, alcohol. If lot of relations are there with a young boy, and you will not be able to ask, do you take an alcohol or not? So you will have to take into confidence, take on the side. And these two important questions, smoking and alcohol, you have to have a personal level of talking. Otherwise, they will not be able to open that they had alcohol or not. And alcohol is also important. Those who start early age between the 25 to 30, they are likely to develop much more avian than starting after the age of 50 to those people who start after the age of 50 to 60, they may not develop avian, but the younger people they develop, and we don't know what's the reason, but that's our experience is. And if you are going to go into alcohol history, it's very important to know what type of brand, how many pegs. All of you know one peg is about 30, small peg, and big peg is 60 ml. So how many pegs per week or per month and other things, because that is important. Those who are going a very high dose, they are likely to develop very early avian, because it's a dose dependent, which we have discussed. We have discussed in avian chapter when I took an avian lecture. So smoking is also another important factor. This also is one of the cause of the avian, and also it also affects these other systems quite a lot. So it is very important to have a history of smoking and alcohol. Sexual history, most of the patients will not come to that, but very rarely those patients with ankylosing spondylitis or a stiff hip, sometimes they will, if you have a personal interview, they might come they are telling you that I am not able to do it because of the deformity of the hip, which is not very common in our country. And if it is common also, but they don't come out with this idea. Menopausal history is also, you know, that it's very important for us regarding the osteoporosis and all other things. Family background, TB, that's a common thing which we use it, but I don't think it's a very important. Family history dysplasia is sometimes multiple epiphyseal dysplasia or spondyloepiphyseal dysplasia. These are come in the families. So one might, if the patient is very short stature and very short stature, plus trunk short. So if you find that way, then you ask. Otherwise, I don't think you require to ask the family whether you had a dysplasia or they may not know what is dysplasia, whether the short stature or something is there, or you have to find out. Metabolic storage disease are common, but it's very difficult to get that history, like a Niemann-Pick's, Gaucher disease, and fat storage diseases. But it's very difficult to get that history. But some intelligent patients will come to you and tell you, my brother and myself, both we have this. That's the way. Sometimes they might come out, and it might give you a certain degree of clue, which will help you in exam. Inflammatory arthritis like rheumatoid and other thing. I think that's a straightforward answer for you. General examination, you will have to take a height and weight. Very important now is to find out the BMI, because nowadays there's a lot of work going on BMI. So I think many examiner may ask you regarding the BMI. In India, we didn't had high BMI, but last about 10 to 15 years, our BMI is going up like a Western world. And this is also important reason is if the BMI is high, the arthritic hip chances are much more. So if they might ask you what is the importance of BMI. Also, if the BMI is high, the other systems are also involved, and that's a surgical challenge for a surgeon also. Fever, vital signs, as you all know that, pallor. Another important thing you have to find out the lymph glands, the external iliac and inguinal lymph nodes. And you need to find out the stigma of rheumatoid arthritis. What is the stigma? You look at the hand, look at the elbow. So immediately you will know that this lady is got rheumatoid arthritis. Ankylosing spondylitis. He will just come like a stoop gait inside, and he will not be able to look at you. So his neck is completely flexed. So he's got a completely stoop. So that is a stigma of rheumatoid and ankylosing spondylitis. Then you see the just leave it to chest expansion. So now we'll go to the little bit of inspection, palpation, moment, measurements, and special test. So first thing, a lot of people see the gait later on, but I think it's better. It depends on how you are trained. But my personal feeling is when the patient comes in itself, I like to see the gait itself. Rather than taking at the last. Okay, so the simplest of all definition is a mode of walking. That's called gait. And if you want to go into the depth of it, normal gait is a rhythmic, bipedal, biphasic walking in which lumbar spine, hip, and leg moves in unison. That's a normal gait described. So somebody asks you, this is the way you have to describe the normal gait. Normal gait is rhythmic, bipedal, biphasic walking in which lumbar spine, hip, and leg moves in unison. The limping is most common abnormality in the gait. The limp can be painful, can be painless, which will come to it. Can be defined as any abnormality of the normal rhythmic biphase is the limp. Can be defined as abnormality of the normal rhythmic biphasic walking is a limp. That's the way we describe the limp. So there are varieties of limp are there. The common which come to us are most of the time there are 2 or 3 only. There are 6, 7 gaits, but I think basically there are 2 or 3 which are very common as the arthritic hips are. One is your antalgic, that's a painful, that's called painful hip condition. And they walk with a reduced stance phase on the affected side, on the affected side. So they try to take the leg off immediately. Probably you should be able to see this. Look at that, right side, he's got a right side hip pathology. He's supporting and immediately lifting off. So he's not taking the weight on the right side at all. He immediately picks up the leg. Now you'll be able to see better. Okay, he keeps the right, immediately lifts that leg. And that's your antalgic. The waddling gait, body sways from side to side on both the side with a wide base, And this is seen usually in bilateral DDH, coxavara, excised hip, muscular dystrophies, pregnancy, osteomalacia, various conditions we see the waddling gait. Even with a severe bilateral DDH or arthritic hip, we will see a waddling gait because they're swinging on both the side. In even a coxavara, this is a patient with a bilateral degenerative dysplastic hips actually, this is the patient. But he had a, look at this, his waddling. See this waddle, both the side. The right and left both. Look at classical. Okay, so Trendelenburg gait is a double stance. In a double stance, force distributed equally on over the two hips. That's a normal on a double stance. In a single leg stance, force increases to six folds. Patient lurch on the affected side. And the pelvis drops on the sound side. Okay, now this is your affected side. Patient is standing here on affected side. That's your normal leg lifted up. And now the pelvis is dropping here. Pelvis is dropping on the normal side. That's a contralateral, it drops down. And this sign is a Trendelenburg sign, which is described here. Can one of the candidate tell me how it is, how you do a Trendelenburg test?
Yes, anybody? Yes, voluntarily describe how you do a Trendelenburg test.
We'll ask the patient to stand, sir, with both the legs together, and we'll sit behind on the posterior aspect and look for the two posterior superior iliac spines. Then we'll ask the patient to lift the side, the other opposite side to be lifted off the ground, sir. And we'll assess whether the pelvis is dipping on the unaffected side or not.
Okay. What is the position of the leg at that time or the normal leg? What is the position?
Normal leg, it is in stance phase, sir. And
yes. How will be the hip and how will be the knee?
Okay, sir. Normal. In case of a Trendelenburg test positive, the normal leg will be flexed, sir, and hip is flexed and knee is also flexed, sir.
Is completely wrong. If you look at the das very carefully, your hip should be either neutral or it should be slight in extension and the knee should be in flexion. If you flex the hip, it stabilizes the pelvis and you will get a false result. This is a common mistake done by all the students, including examiners.
Okay.
So one important message from my lecture. Please do not flex the hip. If you flex the hip more than 40 to 50 degrees, the pelvis gets locked and does not allow to drop down. Is it clear?
Yes, sir.
Because iliopsoas stabilizes the pelvis, does not allow to drop down.
Yes, sir. Yes.
Yes, sir.
You have to keep the knee flex and hip either neutral or a slight extension, whatever it is. Many patients have a little FFD, 5 to 20. That is all right. If the patient has got a severe flexion deformity, this test is actually contraindicated. But many examiners may not agree on you. Number two, as far as we were concerned at the time, with a stiff hip or ankylosed hip, this is not possible to do the test. Okay, if any examiner you are going to get a gold medal, he might ask you these are two or three important questions. Okay.
Yes, sir.
So that's already I had described you. That's a normal. That's normal, and that is the pelvis drops on the sound side. Sound side. Oh, there is one more. The video is gone. Okay. Oh my dear. Okay. Okay. Then we have a short limb gait. Here, most of the time in a short limb gait, patients, they don't have pain. It's a usually painless limb in a short limb. Whether as in antalgic, it is a very painful limb. Here, usually it is a painless, and here the shoulders drop down on the same side. When the affected side becomes short, up and down movements of the half body, patient lurch on the affected side with a pelvis drop on the same side. Whereas in Trendelenburg and antalgic, they are throwing their trunk on the opposite side. And now look at this video, then you'll realize. It's the right side. See that? It is dipping down on the same side, right side. And his stance and his face are both equal almost. Look at that. He drops the whole thing on the same side. The trunk is not thrown on the opposite side. In a Trendelenburg, exactly trunk is thrown on the opposite side. That's a major difference between the short limb, Trendelenburg and antalgic. Circumduction gait, which is a fixed abduction deformity in which, especially in hemiparesis and other thing, all of you know, they will be dragging the leg. It's a very, very straightforward circumduction one. This is a very rare, which happens. A gluteus maximus gait. We don't see much of them. This is mainly a paralysis of gluteus maximus. This usually in the polios. Patient lurch backwards during the stance phase. As you see this lady who has she has a weight bearing here, and the whole trunk is back. Whole trunk is backward. So this is very classical of gluteus maximus, which happens in the paralysis of gluteus maximus, in polios. So very rare to see this gait. And today now we don't get much polio, so unfortunately we will not be able to see this type of gait. So the quadriceps gait, yes, we do see this quadriceps gait. This is weakness, quadriceps weakness, weakness of the body. The collapse takes place, and the trunk goes anterior, bending to the shift the vertical vector anterior to the knee, which we have to balance. So if you look at that, the center of gravity is going in the front, just to balance this weak quadriceps. So that's why you saw the gluteus maximus behind. In the quadriceps, you will be front. So that's the way you keep in the mind, quadriceps gait. And this is usually most of the people try to put the hand on the knee, and that for stabilization of the knee, so that they try to put the knee into slight recurvatum, push the knee backward, and that's the way they stabilize. So that's a very classical quadriceps gait. We again see a lot of polios, we see this gait. Intoing in children, this is for children, not for adults mainly. The intoing and outgoing gait is very classical. You see them. Patient walks with both feet turned inside, and that indicates excessive femoral torsion, or sometimes they can have a tibial torsion also. So they have an excessive intoing gait. This is very classical with the children. Toe outgoing gait, patient walks both the feet totally external rotation. That's usually in the femoral retroversion, retroversion of the femur which occurs. So this is mainly for children. Then we come to the attitude of the limb. Once we have seen the gait, we have seen them. Then we'll come to the attitude of the limb in standing. You are going to see these patients from back, from the side, from the front. Unfortunately, you can't see from the top. Okay, so we have to see the position of the head, level of the scapulas and the nipples, curvature of the spine, what is the attitude of the hip and knee and ankle, all the three. So you are looking at the spine attitude, you are looking at the knee, you are looking at the hip, and you are looking at the ankle. And looking at the anterior superior line, whether they're square or oblique, you are seeing from the front, and from the posterior iliac spine, you can see from behind. So you are able to see, when you see this patient, most of the time you will have an idea which hip is involved and whether he's got a fixed deformity or not. Or if we are looking at the spine, whether this patient has got an ankylosing spondylitis or something else which he has got. That is the way the spine itself will give an idea. Then what about the position of the limbs? They are parallel, rotated, whether they are external rotated, whether they are internal rotated, whether the patella is facing inside or outside. Any patient has got any knee flexion deformity. That knee flexion deformity can be sometimes can be compensatory, or maybe having another additional flexion deformity of the knee, maybe due to rheumatoid. So we have to take it out whether this is related to the hip or whether it is related to the knee itself. Exaggerated lumbar lordosis, you have to see that the couch has to be a flat one. The patient has to lie down on the flat. Don't allow me to sleep on the floor. If there is no that type of bed, you can always tell the examiner, unfortunately, sir, I don't have any hard bed, but don't allow the patient to lie down on the floor. It doesn't look nice. Exaggerated lumbar lordosis, you have to see. We have to see SARS, sinus, branding mark. Branding mark used to be very common in when we were housemen and registrars, but today we don't see that much. Anybody knows what is branding mark?
Yes. Anybody?
Superstitious belief due to which the skin is marked with some hard tissues.
Skin is marked with?
Some like hot marks are kept, sir.
Yes. With iron, something like that, with the iron material, varieties of material. They are red hot, and they just put it on the where there is area of pain, and they try to put it on the skin where the pain factor is. So it heals by secondary intention, and you will always possible to differentiate between surgical scar and branding mark. So that's the way branding mark used to be initial. Now today we don't see much branding mark. But some old patient, suppose, comes at the age of 70 with arthritic hip or arthritic knee, so they might be having this branding mark, very classical. These are counter-irritant mechanism. So you are going to see from the back, scoliosis you will see. You are important with vesting of the gluteal muscles. That gives a good idea that this patient has a chronic arthritic hip pain. If gluteus is vested, it doesn't vest in acute traumatic injuries. It will vest only after 6 months, 1 year, maybe more than that. So that is important to know the vesting of the muscles. And the gluteal fold, you will see, this fold is very important in children, not in adults, where you see the gluteal fold in a DDH, that is different. Then you look at the posterior superior iliac spine, the back of the iliac crest, any SARS sinuses from behind, which are missed from the front or side. So it is easier to see these sinuses or scars. Then you just roughly have an idea what is a limb-length disturbance. You are not going to do anything. You are not touching here. You are not doing anything. You are just going to see this external rotated, flexed, scars, sinus, lumbar, and length. Obvious shortening. If there is obvious shortening, you are going to describe. Here there is a He is trying to put the hand, but you are not supposed to touch. Then you come to palpations. Confirm your finding on whatever the session. Then you take the local temperature if there is a swelling or anything. Most of the time, hip examiners, they all want that you should do this test. But as far as I am concerned, the local temperature is not important in the hip because it's a very, very deep structure and it will not, able to. Anybody knows how do you put a temperature? How do you look at the temperature? Anybody?
Yes, anybody?
Auxiliary temperature plus 2 degrees centigrade.
No. How do you on the hip?
Local.
How do you put a hand?
Dorsum of the hand is used to measure, compare with the opposite.
Why not palmar?
Palmar is for sensation, touch sensation, sir, and dorsum is for the temperature sensation.
Yes. There are special fibers, and that's the reason we touch with the dorsum rather than a palmar. There are special fiber for the temperatures. Okay. Usually in children, yes, when they are acute septic arthritis, that is the time we will have a look at the very important to touch the hip for the temperature. So not in arthritic hips. Then we have joint tenderness. And this is again, a lot of examiners have fancies of where do you palpate the acute tenderness in joint line, because most of the students are going to tell the examiner, sir, he's got anterior joint line tenderness. So where is that anterior joint line? So that you must know that anterior joint line. This is very difficult practically, but as a student, you've got to tell them what is anterior joint line. Anteriorly 2 centimeters below and lateral to the inguinal ligament, that is your tender spot. If you tell the examiner, he will be happy. So that is your anterior joint line. Where is the posterior joint line tenderness? It is not the same. It comes a little different. So posteriorly, junction between medial 2/3 and lateral 1/3. So it is much more medially. Medial 2/3, more laterally. So medial 2/3 and lateral 1/3 junction. That is the area the posterior joint line tenderness is. Clear? So tenderness, all other tenderness, joint line, greater trochanter, pubic symphysis, sacroiliac, ischial tuberosity, all that area you have to start palpating. This sign we will take it slightly later because it has come unfortunately in the palpation. So we will take it into the special. Palpation of the greater trochanter, whether it is smooth, irregular, whether it is proximally migrated or not. Then we do what is called digital branch triangle and during the palpation itself, but we will also do it as a special test. But as far as the palpation is concerned, at the same time, we are going to do a digital branch triangle, whether this is supratrochanteric shortening or not. And that will give an idea. This greater trochanter palpation is palpation you have to do on digitally only. So whether it is a rough, whether it is tender, whether there is a deformity, whether if there are scars there, then you have an idea this is operated. So you're likely to get a thickening of the failed fracture neck femur or something. You are likely to get a thickening of the lateral side. So we'll have to keep that in mind. So we just have the measurement of the deformity, fixed fracture deformity, which is described by Hugh Thomas. Here, examiner blocks the pelvis by bringing contralateral sound hip into maximum flexion. This eliminates the lumbar lordosis that can be used to compensate for the hip flexion contracture on the affected side. So it is a compensatory phenomena done by lumbar spine, which you want to block it. And that's the reason you are blocking the principle. I'm talking about the principle of this flexion deformity. So you are blocking that by doing the non-affected lip. The leg to be examined is brought into maximum extension with a hip in neutral, adduction and rotations. Whatever rotations are. So examiner blocks the pelvis by bringing contralateral sound him into maximum flexion to block the lumbar lordosis till it obliterates. I am coming to that fallacies in just in a couple of slides. How wrong people can do this test. This is you have to keep the hand down in the lumbar spine area. There is a lordosis, and you just flex the normal hip and try to obliterate, and just as it obliterates, that is the only area, you don't flex beyond this. If you flex beyond this, you will get a false impression of excessive flexion deformity, which patient does not have. So, if you look at the very carefully with these patients, normal activation of the muscle during the hip flexion, rectus abdominis, and that's your flexion here, and muscle 4 couples, imbalance pattern, weak rectus abdominis, and which allows the anterior tilt of the pelvis to take place, which increases the lumbar lordosis. And if you have a bilateral FFD, there are two ways to examine this bilateral FFD. You can make the patient prone, and you can test one by one. If you cannot do this test, anybody knows how to do it in supine position?
Yes, anybody?
We'll take the patient to edge of the table and bend both the hips, sir, and extend each hip one by one gradually, and look for the remaining flexion deformity in the opposite hips.
No, slightly better. Anybody else?
Yes, anybody wants to describe it?
In a prone position, in a supine position.
In your exam, you will definitely be asked this question. Every student should know this question. Anybody?
Okay. Let me go. Patient in prone position with the lower limb hanging out and then the edge of the table. Patient should be able to keep the thigh extended. Here, most of the time, you might require the help of somebody. You can't do it alone. So somebody has to support one leg. So you will have to tell somebody to come and help you. An examiner might ask you, you did alone or you did somebody. If you said you do alone, that means you did not do this test. Be careful because somebody has to hold the leg of the opposite side. And then you measure the angle with thigh with a bed. That's the way we do it. You see that, okay? Now, if it is a bilateral, what you should do, flex both hips till lumbar lordosis is obliterated, not over, okay? Ask your patient to hold one knee into that flex position and start, suppose now this side, right side, start extending the hip and see the reappearance of the lumbar lordosis. Suppose it goes into about 40 to 50 degrees, that is the degree of deformity on this side. Again, you flex the right hip again, both the hips again, and then go on to the opposite side and extend the left hip gradually till lumbar lordosis reappears. And that is the deformity on the opposite side. All of you got clear? Reappearance of lordosis and then measure the deformity. All of you are clear?
Yes, sir.
Yes, sir.
Yes, sir.
I am repeating again. Flex both hips fully till lumbar lordosis is obliterated. Then start right side hip extension and look at the reappearance of the lumbar lordosis. As reappearance, that is the amount of deformity on the right side. Same way you have to do in opposite side, flex both hips, start extending the left hip. So this is one more important test for a bilateral FFD. Lot of criticism. Painful hip, it hurts the patient. Obese and heavy patient, difficult to appreciate the lumbar lordosis. It is very difficult. Bilateral deformity problematic, I told you. Amount of force may alter the measurements. If you are forcing too much, you will get excessive additional flexion deformity, which you should not. Bony ankylosed knee in extension is sometimes difficult to test the deformity. So there may be difficulty of criticism in this group of patients. This gentleman who described, you might get a short note on this historical short note, Hugh Owen Thomas. Anybody knows from where this gentleman is?
Yes, anybody?
France.
Huh? My dear.
He's from British. He's from British only, sir. He's from British.
Ah. Where? From Britain? From where? Which part of the country? You should know Makkah of orthopedics. Anybody knows Makkah of orthopedics? Is a Liverpool.
Liverpool.
The all orthopedics started right there. He was orthopedic surgeon or something else he was?
He was a bone setter.
Yes, he was a bone setter. He was not an orthopedic gentleman, and he had a lot of problem there when he was practicing as a bone setter, and he had a lot of even cases against him because of the bone setter, and he had he went into a lot of frustration because of the cases, and that's why what he did, he trained his nephew. Anybody knows his nephew's name?
Yes, anybody?
Who brought modern orthopedics because he was trained.
Yeah, father of modern orthopedics.
Robert Johns. Robert Johns was he was trained orthopedic surgeon, and he put whatever his ideas of Human Thomas was ideas into practice with academic background, and that is the reason Hugh Thomas was much more. Robert Owen was much more popular, and he did a lot of work because all over the world people used to come and watch this Robert Jones operating or looking at the patients and everything. His clinical notes were fantastic. His operative notes were too great even during that time. And a lot of research work also he did. And on Sundays, he was a very rich guy on Sundays, but he used to see a poor patient in his bungalows from morning session. So all the patients were looked free during that session. Otherwise, he was a great gentleman. And now the Thomas, if you get a short note, I think you'll have to go all the details of this. The Thomas splint was devised by him. Thomas Heel. Anybody knows what is Thomas Heel? This heel.
Yes, anybody? DNB students must know this.
Shoe insert. Shoe insert, sir.
Huh?
Shoe
Yes,
insert. Is it a shoe insert, sir?
No, this is called as the heel, shoe heel, there's a heel which is long, elongated, and one side it is raised. This is done for the deformity of the congenital deformity of the foot. That's called Thomas Hill. Thomas Hill. So you just go through the literature and read around. This instrument, anybody knows this instrument?
Thomas Wrench, sir.
Yes, Thomas wrench. What for it is used?
Don't know, sir.
Acha. So this was done for osteoclysis and as well as for club foot correction, club foot manipulation. Then for calcaneal calcaneal fracture reduction. So this is the way the Thomas wrench was used. I had seen this my boss using when I was houseman. So we do have Thomas wrench in the hospital. Anyhow, you will have to go to the short note because you are likely to get a short note, or any old examiner is likely to ask you a couple of things regarding the Thomas, and Thomas. He's on 11 Nelson Street. I had opportunity to go and see his house and his clinic there when I was doing my MCH. It is still there in Liverpool.
Sir, how it is used, sir? Like Thomas Wrench?
Yeah, this is adjustment. You have an adjustment here. See, this is this moves. This this distance can be reduced, can be increased, and you put the foot inside and turn it. Club foot.
Okay, sir.
Turn it. Or in osteoclasts, you can break inside, put it at the level where you want, and tighten it up fully. So you have one support, and then you break that.
Okay, sir.
And calcaneal, you can just compress it so that the reduction takes place.
Okay, sir. And the clavicles, that neck collars, sir?
That's a Thomas collar. That's for the cervical spine. This all is done by this gentleman.
Okay, sir.
There are a lot of things are there, but I just put a couple of things. You will have to, if there is a short note for 5 months or 3 months, you will have to write down everything. Branch triangle we described already. Now we are just going to the some deformities. We are looked at the by digital palpation, which has been done already. We have already done the local inspection, examination, FFD, everything is done. We go to the adduction deformity and abduction deformity. Fixed abduction deformity are not very common, but the adduction deformities are much more. Almost 70-80% are usually on adduction deformity, but once in a while you are likely to get an abduction deformity also. Abduction. So this is apparent usually lengthening of the leg. And now you look at the lady, the leg is longer on this side. Longer on there. So the pelvis has dropped down on that side, and the opposite side has gone up. So the pelvis has become oblique, and this leg has become longer. That's called apparent lengthening, which has taken place with the abduction deformity. So this is compensated by scoliosis with convexity towards the affected side. Exactly, it becomes the adduction deformity is opposite. If you look at very carefully here, is compensated scoliosis, convexity. This convexity is on the affected side, and the pelvis is tilted down, causing apparent lengthening. The scoliosis is on the same side, convexity on the same side of apparent lengthening, in abduction deformity, and exactly is opposite in adduction deformity. Clear? So scoliosis on the same side. In the fixed adduction deformity, this compensated scoliosis, convexity towards the normal side. See, this is the adduction deformity on this side, and the scoliosis is on the opposite side. It is not on the same side of the affected. It is opposite side towards the normal side, and the pelvis is still causing the apparent shortening. So examiners are likely to ask you, if there is an apparent lengthening, which side is the scoliosis? So you have to keep the mind the same side. In adduction deformity, the scoliosis will be on the opposite side. That's a compensatory mechanism which we develop. So basic, put a mind so you'll have an idea. fixed abduction adduction deformity can be just known by just putting your thumbs on the anterior superior spine. That is more than enough to know this patient has got adduction deformity or abduction deformity. Anybody knows how to palpate anterior superior iliac spine?
Yes, anybody?
We'll go from the pubic tubercle, sir,
Yes.
laterally over the inguinal ligament. Felt
Yes.
bony prominence is anterior superior iliac spine.
Correct. Correct. So that is the only way to palpate. Don't put exactly the hand on that. Okay. Just give me a half a second. नंतर फोन कर दो. That's the way we do the anterior superior spine. That gives an idea. If affected side anterior superior is on the higher side, that is the adduction deformity. If anterior superior spine is on the lower side, it is an abduction deformity. It is straightforward. Unnecessary examiners are going to confuse you, so you make it very clear in your mind. So anterior superior spine at higher level is adduction deformity, lower down is an abduction deformity in a affected side. That is the way we do it at abduction adduction deformity. So now this patient, now anterior superior is the higher side. This is the affected side. That's a normal side. And now this patient has got an adduction deformity. Straightforward. So don't get confused at all. And in abduction deformity, this will come down. And how do you square them? Because when you want to do some measurements, you got to square the pelvis, which will come to later on. But you got to square the pelvis. Now, patient has got adduction deformity. Anybody can tell me how do you square the pelvis?
Yes, anybody? Yes, please take part in discussion.
First, we will try to in adduction deformity, the pelvis will be in a higher position. Position, sir.
Yes.
We'll try to bring it to the bring the leg to the towards the opposite side, sir, so that the pelvis drops down, and slightly we'll try to slightly abduct. Slight abduction force is applied, so that the free range of movement is eliminated, sir. And after the the pelvis doesn't move, and once both the anterior superior iliac spines are at the same level,
you are not going to abduct.
Just move the limb in opposite direction, so that free range is eliminated, sir.
Yes, adduction. Don't say opposite. Just fixed adduction deformity is to be corrected by adding the adduction more. So you are going to continue the adduction force and not an abduction.
Yes, sir. Yes, sir.
Yes. So you are going to adduct the hip till it becomes a square. It becomes on the square, and that's the deformity you count as a fixed adduction deformity. And in abduction deformity, you abduct the hip, not adduct. So it is the same movement you have to use. So examiners are likely to ask you, if there is a fixed adduction, can you abduct the hip? So you got to tell them, I cannot abduct, I can do further adduction, but I can't do abduction. Once you say it is a fixed deformity, that opposite movement does not come. They usually try to unnecessarily confuse you in the exam. So be firm and clear. If patient has got fixed adduction deformity, further adduction may be possible, may not be possible. No abduction. I am not even going to test you. Tell them. I am not going to even test. No question of doing that. So that's the way
Sir,
to do it. Go ahead.
Free range of movement, we have to correct it, no, sir.
Where is the free range of movement, dear?
Okay, sir. Okay, sir.
What about the fallacies of this? There are a lot of fallacies in abduction adduction deformity. There are a couple of things are there. Squaring is not possible in a fixed scoliosis when there is a lumbosacral fusion has taken place. There is a fixed pelvic obliquity. You will not be able to square the pelvis because there is no compensatory mechanism at the lumbosacral junction. Especially ankylosing spondylitis is a bamboo spine is a completely fused. So you will not be able to do a pelvis squaring the pelvis. Iatrogenic. Suppose the anterior spine is LX spine is during grafting as removed. So you don't have a fixed bony point. If there is a suppose scar of the bone graft, so you got to tell the examiner, sir, I may not be able to give accuracy because there is already scar there. Probably surgeon must have taken out the anterior superior iliac spine. I do not have a landmark. You have, suppose there is a fracture acetabulum, there is a malunited pelvis, hemipelvis. So you are not going to get the pelvis square. Unreduced sacroiliac joint, the whole sacroiliac is subluxated superiorly. So you are completely changed on the anterior superior spine. The malunited iliac wing fracture. These are a couple of conditions where there is a possibility that you will not be able to square the pelvis. And if you are going to hit the medal, then you know all these points. So these are important points where you difficulty to do a squaring the pelvis. Most important is the ankylosing spondylitis where completely bamboo spine fused. You will not be able to square this pelvis at all. Then we come to fixed adduction abduction. We have completed the fixed flexion. Then we come to fixed external rotation, internal deformities. It is always usually it is very straightforward relief. You will find out, determined by noting the direction of the anterior surface of the patella or toes when the foot is held in the right angle to the leg. Normally, we don't look at the foot. Actually, the patella is the most important rather than the foot, because you can have a secondary deformity in the foot, you can have a tibia fracture, you can have so many things. But I think basically you got to see both. Most concentration is on the knee patella, where it is external on external rotated, or it is inside. Usually, most of the time, it is an external rotation deformity rather than internal rotation. Internal rotation deformity is only in DDH and in dislocated hips most of the time. Otherwise, most of the time, it is going to be external rotation deformity. You have to keep in mind. So when you are examining this patient, also you keep a back of the mind what is the diagnosis. If you say patient has got arthritic hip and severely malunited fracture neck, intertrochanteric or something, and you will say internal rotation deformity, you are in trouble. So use common sense. Fixed adduction deformity, I think we have taken this already. Okay. This I already taken it on both sides. Okay. So there is an alternate method of measuring the fixed adduction and abduction deformity. This is Kothari's method of Kothari's line or angle. Anyone knows who is Kothari?
Resident in the Grand Medical College.
Huh?
A resident. Previously, he was a resident in Grand Medical College.
Yeah. He described when he was a resident doctor. But after that, he moved to KM Hospital and he was the head of department of anatomy for many, many years. Just recently, he died. Recently, just about a year back, he died. Anyhow, this is ML Kothari. His name is ML Kothari. I forgot his first name, but it's a ML Kothari method. It's a very, very straight.
That's Manu sir. Manu Kothari.
हाँ मनु, लेकिन वो निक नेम था, लेकिन अलग नाम था उसका कुछ.
Okay sir.
मनु बोलते थे सब, लेकिन उसका नाम कुछ अलग था. Anyhow.
And he was in second year of that Grand Medical College when he described this.
Yes. And then he moved. I told you he moved to KM Hospital as head of department.
Yes.
Head of department.
Yes, sir.
He has written a book also. He has written 2 years back. It was published.
Okay.
Published.
Okay, sir. Okay.
Anyhow, so it is a simple way of doing this. Now, if you look here, this is the anterior superior on this side, right side. This is on the suppose left side. We draw a straight. There is a central line. There is a central line from the episternum, pubic symphysis, and down lower limb, and we put a right angle to this line. This is important. Because this central line is important to put a right angle to this, and we join this anterior superior to the opposite side, and that's the angle here. And this is the again another right angle line which is extended forward, and this is another angle which here, and that is the Kothari's line and angle measurements. So this gives an idea if the affected anterior superior spine is on the lower level, that's your abduction deformity, which I told you. This angle will be different. That will be this angle. If the patient has got an adduction deformity, the angle will be on the other side. So that's the way we measure the angle in fixed adduction and abduction. Both it is possible to measure with Kothari's method. Fixed external rotation, internal rotation. Already this is coming back again. Okay. That is about the couple of deformities. Now we'll go to the little bit of moments of the hip. So usual flexion is around 130 degrees. You can do either in the sitting or in lying, whatever is possible. For iliopsoas contribution, flex the knee and move it towards the chest without moving the opposite leg. When the patient sits, when the leg is hanging on the edge of the examination couch. This is to test. Don't do this test as a moment of the flexion, how much patient. The most of the time the flexion is done in a supine position. This is just a iliopsoas contribution which we are examining. So as far as the hip movements are concerned, you do in supine position, amount of flexion, putting the hand on the anterior superior spine, keeping your thumb on the anterior superior spine, and then try to move the flexion. As the anterior superior start moving, you stop that. That is the amount of movement. So all the time when you are testing any hip movement, all the time your thumb has to be on the anterior superior spine. That is your master finger there. So any moment, start moving the anterior superior, that is the moment which you have to stop. Active SLR resistance, sometimes you might have to do it. The extension usually is around 20 degrees, and that you have to do it in the prone position, and you got to keep the knee flexed. Anybody, why?
Yes, anybody? Anybody? Sir has already written there.
Anyhow,
Hamstring contribution.
Yes, you have to keep the knee flexed, and then you ask the patient to extend the hip, and that's the way we do the gluteus maximus testing. Because otherwise the hamstring will take into hamstring are likely to, because I told you is a biarticular. One is I had told you this is one of the important. One is the rectus, and second is this hamstring. These are the two sometimes do little problems. So again, abduction. Look at that. Your thumb or fingers should be on anterior spine. Here there is one more. We do it, but this is many examiner may not like. So what normally I do when I'm going to do abduction adduction on the affected side, I lock the opposite pelvis. By excessive abduction, I put that hip into almost extreme abduction, and I lock that pelvis, and then I start moving the affected side. But many examiner may not like, so don't mention. If anybody asks you, have you got any another thing? Then you describe this. You lock the pelvis on the opposite side, okay? And then you put the hip into motion, into adduction, abduction. That is usual which will takes. Once it starts and to start moving, that is the moment the patient has. The rotations are done in two ways. One is in extension and other is in flexion. Anybody know why?
Yes, anybody?
Different arc of movement is present.
Huh?
Why?
The superior portion goes into the posterior part with hip inflections.
Different quadrants come into place in both the positions.
Yeah, this is called sectoral sign.
Also.
That is important. That head, the basic is, don't talk on an anterior superior, otherwise they will confuse you and examiner will start talking and all, will take the other side. Why? This indicates the head is not congruous. That means congruous head sometimes come into extension in different, and in flexion it will be different. And that's why it is called sectoral sign, or it indicates the head is not congruous. So that is important. So we do in extension and we do in flexion also. So that's the way we do it. Keeping the foot, going to the foot end and trying to do this test is not ideal. This is not ideal because there is a lot of compensatory movement takes place in the ankle and the foot, and you will get into false. So the best examination for internal and external rotation, this is the way it has to be. You have to hold the patella and upper part of the tibia, and then do rotation, internal and external rotation. That's the ideal way. Don't do this in full extension. So do it this, and in flexion you do it in this way. Here also, is it right or wrong in this he's doing, gentleman is doing? Anybody? Is it the right? This is the external rotation he is doing. Is it right way?
Yes, give your comment. JV Kishore, what's your view?
See, his hand is not an anterior spine.
It is pelvis is not fixed.
Yes, so that is the reason it may not be right. So actually a single person is difficult to do it. Sometimes you might need sometimes help to know. Somebody has to put a hand on the anterior superior spine, and it starts moving. Then you tell. So the learned person should be able to be there to assist you. Otherwise, this is not the ideal way. Or as an experienced person like ours, we just watch. Instead of palpating, we will watch anterior superior spine moving or not. So that's a very gross. Okay, so that's the way it has to be. So you are not the you got to put the thumb on the anterior superior spine during extension and as well as inflection. That's your internal rotation. So again, this is not good. You got to test this way and you got to test this way. So this is, don't do this. Many examiner will not like. The measurements regarding the shortening, you have apparent and as well as the true. Apparent is just you have to test the limb, whatever the limb positions are in the, put it in a roughly identical position and try to measure it, and then square the pelvis and try to measure the true measurements. You have to do it to the level of the knee, to the ankle. If there is anything which is additional malunited femur, another thing which can be, which you can pick up on that separate measurements. So whatever the functional lengths are, so patient is straight line, limbs are parallel, deformity is not corrected, just let it lie like that. And from the fixed point, either you take the GP sternum or umbilicus. Many people like to take a GP sternum. because the umbilicus is a moving structure. Then you measure the limb from there to the medial malleolus, then to the adductor tubercle. That's the way we do the measurements as a functional measurement, that's an apparent measurement. Then we will true measure, we will try to do it with a pelvis width square, and then again we will measure what we told you already, that squaring the again from anterior, then you take the from anterior superior spine to the adductor tubercle and then to the medial malleolus, and you can find out the what is the true shortening patient has. This is another way called block method, which is very ideal. Many people keep these blocks in their consulting room. Those who are doing a lot of limb lengthening practice, they also do it this and just go on putting the blocks by quarter inch blocks, and then you palpate the anterior superior spine, and the anterior superior spine should be now parallel to each other, and that is the amount of shortening this patient has. But here, patient lumbosacral spine should be free. Then only you can do this block method. If it is a fused spine, you will not be able to square the pelvis, which I already told you. So block method is a very good method of measuring the exact shortening. You have to stand in front of the patient and palpate both anterior superior spine all the time. Go on putting the blocks. I think we have taken off this. If true shortening is more than apparent shortening, look at that. If true shortening is equal to apparent, is about 1 inch here, 1 inch there, you don't require any compensation to be given. So we don't need any extra shoe raise to given to this patient. True shortening is more than apparent. Only part of the deformity is compensated by tilting the pelvis here. And true shortening is less than apparent shortening in a fixed adduction deformity. Here also there is with no compensation required. Only you will require is the true shortening is more than apparent. There only you will require some amount of compensation. And every 10-degree deformity is 1 centimeter. That's rough, but don't mention in the exam, please. The segmental true shortening, sometimes children, I think this is the most important test we do as a Ellis test or a Galizia test. We try to flex both the hips and both the knees and try to see from the side which side is the shorter. And this is usually we do see in a DDH. But young adults in a dislocated hips also we sometimes we do see in a posterior dislocation hip. We do see this test, but not very common. Regarding the segmental shortening, now if you are going to talk on supratrochanteric shortening, there are various lines which you need to know. Something like this, we already discussed the branch triangle. We had done a bidigital palpation, but now we are going to do exact measurement of this. We are not only now finger, now we are going to get a sketch and diagram. We are going to put a drawing line from anterior superior spine to the perpendicular to the bed, one line. Can give me 1 minute? Hello? I'll call you on the webinar. Okay. Okay. And then that is your greater trochanter, and this is the distance we are going to measure on the both the side, normal side and opposite side as well. This is your branch triangle, which is very commonly every examiner is very fond of this. Okay, and the same thing which is now as a Knelton line, you draw a Knelton line from anterior superior spine. This is your greater trochanter, and that's your ischial tuberosity. Normally, trochanter touches this line on the latest line. If the trochanter goes up, that means you've got a supratrochanteric shortening. Both can show you a supratrochanteric shortening. This line is another important line which is described as the two anterior iliac spines, the joint lining two iliac spines. and two greater trochanter. They should be parallel to each other. And if there's a disturbance on one side, that means supratrochanteric shortening has taken place. Shortening has taken. The other line is a shoemaker's line, which is drawn from the greater trochanter, anterior spine, and it has to be crossed above the umbilical. And if there is supratrochanteric, this line will go below the umbilicus. So all these are related to supratrochanteric shortening, various lines. Then we have Morrison's bitrochanteric test. It measures the distance from the trochanter to the symphysis. Now this distance from the greater trochanter to the symphysis pubis, both the side is done. It is only dislocated hip. This change. Central dislocation, it will reduce. In a posterior dislocation, lateral dislocation, it will increase. So that's the way we do a Morris's bitrochanteric test. Then, where do we get a supratrochanteric shortenings? We have to keep in mind, these are the common conditions. So you don't go on a rare and then try to match up this. So you have to keep in mind there are very few conditions you have supratrochanteric shortening, and other are infratrochanteric. So try to clinical diagnosis, put a clinical diagnosis, put your mind, put a common sense and try. Most of the time during examination, you go on the rare diagnosis and then that does not matches. So supratrochanteric shortening are common with Coxa vara, Perthes, and now this slip epiphysis is not common in our country. So don't keep it as a first diagnosis on the higher level. So that should be very last to come. So what normally your students are, they start with slip epiphysis and they have never seen a slip epiphysis in their 3 years of tenure. So that's the way you unnecessarily get trapped up. Malunited fractures, yes, that's a common thing which occurs. Congenital Coxa vara and Coxa vara, they are same. Arthritic conditions and dislocation, yes, definitely there is no question. So fracture dislocation, malunited fracture femur, these are the common diagnoses. Then comes Perthes, then lastly comes Coxa vara. So this is the way it should be. Then infratrochanteric shortening are malunited femurs, subtrochanteric fracture, growth, polios, all other infective patha. That's a different ball end. So you will have to see which are the common condition in supratrochanteric and infratrochanteric. So as far as you are concerned, most common is malunited femurs and tibia. They are infratrochanteric shortening. Okay. Then we measure the muscle girth, and that usually do it about 5 to 7 centimeters from above the adductor tubercle. That is a good muscle mass there. There are no much tendons. That's why we try to get it at slightly at the higher level rather than at the level of the knee. So if any examiner asks you, why do you want to measure there? Why do you want to measure there? So you have to tell them, this is we are going to avoid the tendon portion. That's why we are getting about 5 to 7 centimeters above that. That is the level we will measure. Some examiner might ask you, why not at the higher level? So that the moving bulk is too much. That's why we don't do it at the higher level. Because as you take the tape little tight and loose, then becomes difficult. There are a couple of special tests which will, Thomas test we have done, Trendelenburg test we have done, instability test for neonate we will see, gait we have done, a few other telescope with Thomas we have done it. So this is one important which I forgot. Okay. See now, that's a normal test we do it, lumbar lordosis obliteration. Here, we have flexing the hip and getting this flexion deformity. And if you do over flexion, now look at this. If you do over, then your flexion deformity becomes much more. If suppose this is 40 degrees, now in reality is only 20 degrees. So do not flex the opposite hip heavily. It is only till the lumbar lordosis is gone. That is another important message for you. You are testing the hip the patient is standing on. I think we describe all this. Sound side sacs. This is one, keep in mind. This formula you keep in mind. Sound side sacs, SSS. That is the way you keep in the mind regarding the Trendelenburg. Normal side drops down. This we have already done it. This test, what is the basic of this test? The test examines the strength of the abductor mechanism. Now we have got three parts in this abductor mechanism. We got a fulcrum, load, and power. The fulcrum is the head of the femur. Load is the body weight which is going, which is almost 3 times the body weight. And power is the abductor. So if anybody asks you, it has these 3 important factors. If anything goes wrong in these 3, you will get a positive test. You will get a positive test. And you can just imagine distance between that body, liver arm, and other arm, which we had described in the, when we did the biomechanics. And abductor power also we described. If one of the things is wrong, you will get a positive test. So normally, in one leg stance, the pelvis is raised up on the unsupported side. Unsupported side. If weight bearing of the hip is unstable, the pelvis drops on the unsupported side. To avoid falling, the patient has to throw his body or her body towards the loaded side. Loaded side. In a classical test, examiner stands behind the patient. If the patient stands on the healthy hip, the gluteal fold on that side drops down. If the patient stands on the diseased leg, the gluteal fold on the opposite side drops down. That is sound side sacs. That is the way we describe. And cause of positive Trendelenburg test are weak abductors. I told you, abductor palsy or a lot of vesting which has taken place, which are not able to lift the pelvis up. That's why it drops down. Secondly, mechanical insufficient hip abductors. Distance between the origin and insertion is reduced, coxa vara, so the abductor liver has changed. Unstable pivot like a subluxation, dislocation, or excised hip. There is nothing, there is a fulcrum is not there, there is no pivot. Inhibited hip abductors, that is a patient has got a very painful hip, he is not able to load it, then it becomes inhibited. And reduced range of motion. Incongruous or stiff or OA. I told you, with a very stiff or ankylosed hip, you will not be able to do this test because mechanism is lost. Mechanism is lost. There is a fallacy with this test, Trendelenburg test, is because of quadratus lumborum. Quadratus lumborum can play a role in affecting normal gluteal mechanism. So look at this, very important things are, quadratus lumborum muscle originates from the wing of the iliac and then insert into transverse process and upper 4 vertebrae and the lower part of the 12th rib or 11th rib. The contraction on one side of this pair muscle can cause lateral flexion of the lumbar spine. And if both they contract, then it will lift the pelvis. It lifts the pelvis, elevation of the pelvis or both sides. So contraction of the both side can cause extension of the lumbar spine and lifts the pelvis up and extends the pelvis. And if one side contracts, it will produce a scoliosis on that side and that side. So it produces a tilt. Now, affection of the quadratus lumborum. If affection of the quadratus lumborum can give a false positive Trendelenburg test because it does not allow the drop down. So it tries to pull that pelvis up. So sound side, instead of sacking down, it pulls it up because of the quadratus lumborum. So there is a chance of fallacy because of the quadratus lumborum. Poor muscle coordination, cerebral palsy, Parkinson, difficult to do the Trendelenburg test. affection of the sacroiliac. Pain is so severe, so you get a pseudo positive test. They are not able to load the hip at all because sacroiliac is very, very painful. Then medial shift of mechanical axis. If there's an excessive bowing or malunited femur, the whole axis changes on the medial side towards the center of gravity. So the fulcrum has changed completely. So you will get a pseudo positive test because the mechanism has changed. Obese patient may be pseudo positive. So these are 5 conditions. I told you: quadratum lumborum, poor muscle coordination, sacroiliac, medial shift of mechanical axis, and obese patient. There is a fallacy of getting pseudo positive test. This test all of you know, but still
Sir,
ah,
uh, sir, I wanted to tell that some residents have left the meeting. So, sir, if the lecture is much more slides are there, we can plan it as a part 2 also on next
okay,
week, because Monday Somesh sir is not taking. He is asking for another week.
okay.
So it will be comfortable to you also, sir.
Yeah, okay.
So we will continue from Monday from Galiazi test, sir.
Okay. Go ahead.
Yeah.
Okay.
And thank you very much, sir. And for today's lecture, if any resident want to ask any question or you are having any query, please proceed. Everything you make clear about hip examination right now, because in exam you are definitely going to ask each and every question about it. So any resident is having any query, please proceed. Okay, sir. So,
Yeah.
sir, we will plan second part on Monday. We'll continue from Galiazi.
Okay.
And thank you very much, sir. Thank you very much for your time and effort, sir. You took it in very detail, sir. Thank you very much.
Okay.
Yeah. Good night, sir. Good night.
Good night.
Good night.